everybody. My name is Soumya Mandava, and welcome to the What the Health podcast, brought to you by the Alumni Association in conjunction with the Renaissance School of Medicine. Each episode, we bring on an outstanding alumnus who tells us what the health we can expect after graduating from medical school. From their journey to their interests to incorporating it into their chosen fields, we get to hear it all. So, let's jump right in. Hi, everyone, and welcome to this episode of What the Health. Today, our co-host is...
Hi, my name is Paige Varney. I'm an MS4 at the Renaissance School of Medicine.
And today, we have the pleasure of talking with Dr. Stiles, an obstetric anesthesiologist at Beth Israel Deaconess Medical Center and graduate of the class of 2010. How are you doing today, Dr. Stiles?
I'm doing well, thank you.
We're so happy to have you today with us, Dr. Stiles. Thanks for being here. Maybe you could start off by just telling us a little bit about yourself.
Very good. So as I said, I'm Justin Stiles. I'm one of the graduates of 2010. Actually, while I was there, I was the Emergency Medicine Interest Group president and one of the environmental club leaders while I was there. But again, I ended up, my path evolved, and while I was there, I got inspired to do anesthesia and chose a different path. I'm married and I was blessed with twins, so I have twin girls. They're 9. One of them has a different path in life. So I have a severe special needs daughter that has a cerebral palsy, and that presents as severe spastic quadriparesis, and unfortunately is nonverbal, and that kind of shapes a lot of the activities that I do. But she has shown me that she loves to ski, and that's a big part of our lives. So she loves to ride in her sit ski, and that's a big activity that I do. I basically work for the weekend, and then I race to Vermont to attack the mountain with my daughter Lucy. I also live in Marblehead, Massachusetts, which is a pretty little sailing town just outside of Boston, and try to spend as much time on the beach and boat with my 2 children as well.
Between the skiing and the boating, it sounds like you and your girls have a lot of fun together. Thank you so much for sharing that. One thing that you mentioned earlier is that you found your interest in anesthesia at Stony Brook. So could you tell us a little bit more about that and your journey into pursuing a subspecialty focus as well?
Well, very good. So as I alluded to, that I was the Emergency Medicine Interest Group president. So I wasn't pursuing anesthesia in the beginning. I actually started it as down a path. I was a non-traditional medical student and was pursuing, it was a philosophy and psychology major at Boston College. I was going to do psych. I worked at McLean Hospital while I was in Boston College and was going to pursue clinical psychology. I was an adolescent, I worked in an adolescent psych unit, and then evolved into, I actually ended up doing a little side thing of being a teacher for, I was a teacher's aide for an elementary school for deaf children, then ended up being a teacher's aide for Asperger's syndrome, which was a mild autism. And then my mentor said, what I was looking for was not down this path. I said, okay, you tell me this now after a $200,000 education at Boston College, but they taught me about post-bac programs, and I ended up, cramming for the MCAT and was successful in getting into medical school. But while I was waiting during that lag year, I, worked on an ambulance and started working at Beth Israel Deaconess, where I currently work still as an emergency technician, emergency medicine or emergency department technician. So I'm doing the phlebotomy, the EKGs, the Foleys, all the fun stuff, and got into med school. And I said, you know what? I know emergency medicine. It was pretty cool while I was there. It was always exciting. No day was boring. I'll do that. And then I started realizing what the emergency medicine doc did, and I started getting a little less excited about it. Because what I loved was the procedures, and what kind of emergency medicine docs get frustrated by is that if they're stuck in a room doing a procedure for 20 minutes, that's 20 minutes that's elapsing in every other room that they're responsible for. So they're just trying to get out of the room. And then when I was on my ICU rotation, we had this really sad story of a head and neck cancer guy that was getting a one last trial of extubation before considering a trach. And we extubated him, and sure enough, the stridor that came out of that guy's throat was the scariest thing I've ever heard. And all of a sudden we hit the panic button, you hit the anesthesia stat button, these two people roll in with a tackle box, walk up to the head of the bed, throw an endotracheal tube in, write a note that was about 4 lines long, said, "Hey, let me know what the chest x-ray says," and walks out of the room. And I was like, while I'm writing up a 2.5-page soap note, and I'm like, I want to do that. And I said, who was that? They're like, "Oh, that's anesthesia." I was like, wow, that was, I'll do that. So I immediately in my MS, 3-year, switched into an anesthesia rotation and ended up finding it had procedure laden, and I was willing to sacrifice some of the things that I had in my head, but had, I was like, I like to say I sacrificed continuity of care to do like the things I love to do, and those are procedures. And it's very concrete because I get someone through a trial of surgery, I get someone through a difficult labor, and in the end, it's done. There is a finality to it, unfortunately. And then I ended up in anesthesia. So now I'm through my, I enter into my CA 2 years, when you start to think about whether or not you're going to get out of the game quick and go into kind of just general practice anesthesia, or you pick a path and extend it a little with a fellowship. I was going to be a pediatric anesthesiologist. And then I had realized that I had my twins during my CA2 year, and realized that I had one with a severe neurological injury. And I knew that I would have an early onset cardiomyopathy if I endured a emotionally trying day working with children, and then also coming home and getting my daughter through the challenges that she was going to be faced with. But I decided to over and over again pick the scab of my birth trauma and talk about my twins being delivered at 28 and 5 and spending 100 days in the NICU during a exciting C-section with an awake mom staring at me with nothing else to do while she's being eviscerated on the table. So I would figure that was going to be my path. I love neuraxial. I am very good at finding midline. So I'm very good at finding a spinal in any shape and size and rotation. I am started as a psych guy, so I'm used to talking, and I'm pretty good at distracting people and hopefully avoiding some mind-altering medications that might be absorbed in the systemic system and then end up in babies. So I'm pretty good at giving you at least 90 minutes of good material and seeing if I can get you past it without needing any drugs. Because of that skill set, my other hat I wear at Beth Israel is regional anesthesia. So you'll find me usually walking junior residents through needling procedures on awake, nervous patients, and that's where you find me.
Great, thanks so much. So like we mentioned, you're working at Beth Israel, and you might have alluded to this a little bit before, but could you tell us a bit more about how the practice of academic anesthesiology is different from private practice and kind of the scope there?
Very good. I just recently got voluntold to head over to one of the more private focused hospitals called the New England Baptist Hospital. And that is a private practice warehouse of joint replacing surgeries. And the majority of those surgeries, knee and hips, are the default anesthetic is spinal anesthesia. And as I said, I'm pretty good at finding midline. And some of those knee surgeries might be offered a nerve block. Also kind of my gig. I saw the writing on the wall when we shook hands with the hospital and figured I was going to be sent over there. Now, private practice focuses on efficiency. Now, academics should also be focused on efficiency, but we end up inheriting many more complex patients. So the straightforward cases that can receive the stamp of this is the path, you get your spinal, you get your antibiotic, you get a antifibrinolytic and sent down the conveyor belt. That is the function of private practice. And it is an amazing to be a part of. They do great work. They are basically one of the best hospitals in the country to receive their joints. And while I'm there, I'm super efficient. I work with great people. But what I prefer is walking a resident physician or working with my fellows on a little bit more complex natures of this care. Like I do joint replacements, and I was on the total joint team at Beth Israel, but I'm doing it with a patient with an EF of 15 or some other comorbidity or severe pulmonary hypertension that just kind of adds another twist to your day, just to put your heart a little further up and rise up into your throat. Now, anesthesiologists, if you're choosing this path, you have to like being scared. That's kind of like a filter. Like if you're comfortable with being uncomfortable and prefer it that way, this is your field. But that kind of layers to it. I like getting a resident physician to kind of come up with their plan. I like that need to be very particular about the plan. I like defending my reasoning. I like being challenged of saying, well, how come we didn't do it this way? It's kind of like a mini oral board for me every day, but it's a little less threatening. And then I've also loved that my other title is I'm the associate program director of the Obstetric Fellowship. So having those guys making sure that I'm doing best practice.
So it sounds like a lot of the work that you do is highly collaborative. Maybe you could tell us a little bit more about working with surgeons, OB-GYNs, nurses, CRNAs, and other providers, and how all that factors into your practice.
Absolutely. I am nothing outside of a team. I do not even carry patients. I am the guy who's sitting in OR 9 today, and I may have 3 different surgeons that come. So working with those surgeons, for good or bad, it's going to be the day that I'm there. The need to communicate and at least be clear about the things that are essential are things that I've become very good at. Regardless of the interaction, I can be clear about what are the expectations of the day. And if you want to have some pleasant banter, I'm up for that too. With obstetricians, there is the one thing that I pride myself on at Beth Israel Deaconess is the type of communication that we have. Twice a day, we're running the list of all the patients we have on, the goals of the care, the goals of the patients, be it a birth plan or otherwise. And in that setting, the labor nurses also have a huge voice in that, because they're going to be that patient's muse. They're going to inspire this patient to do things that they never thought they were capable of. And when you hear some of them barking orders at them while they're trying to push this baby out, man, you think you could. If they were doing it to me, I feel like I could run through a brick wall. I mean, they are wonderful, wonderful, inspiring healthcare providers, and they're my eyes. So when I'm not in these rooms with these laboring women, especially before I've even placed an epidural in them, I don't know who they are, and my time spent with them, I gain a sense of confidence that if there's something that's concerning on their mind, they know that I should be brought in into the conversation earlier. Now, I always like to go and have as many of the moms that are laboring on my floor seen as soon as they come in, but I kind of rely upon them being that first set of eyes and saying, I saw something in their history that I thought you might like to know about. And those are really great things that we have in. And each person has a voice, for better or for worse, during a lot of those conversations that we have. The CRNA thing was something I was not prepared for. Now, I had kind of worked in parallel with him during residency. And then all of a sudden, I'm now overseeing nurse anesthetists. And it kind of wasn't something that was covered during residency. And then now I'm in there and I'm a new grad at the time. And I got some nurses who have been kind of doing this for 15 years. And I'm trying to figure out, like, I had this strict way that I had adopted to, if I do it this way every time, nothing bad has happened. Now, I don't know how many of those steps that I was doing prevented that, but if you don't step on a crack, my mother has an intact vertebrae and she has not broken anything. So if I do it this way, no one gets hurt. So I was trying to learn how to accept an appropriate practice by a nurse anesthetist. Now, there are times where I've learned what will I not bend on. If I say I've had a 20-minute conversation about a patient about post-op nausea vomiting, and I promise them that we're going to do a total IV anesthetic with propofol. I'm going to minimize opioids, and this is going to be my plan. And yes, it's a little bit more labor intensive for the provider in the room, but I'm going to advocate that this is the plan for this case, even if they may have had one that was counter to that. I have new information from being at the bedside of the patient. So there's things that I will flex on, and then there are things that I will not waver on. I wanted to make sure that my patients in the end got the best care.
I think one of the best parts of this conversation has been your genuine excitement for your work. It really comes across how much you love what you're able to do.
Oh, I get it. I am blessed that I get a buzz from clinical care, because it's kind of ends up being the thing I end up doing. And if it's a lot of work. And some of it is hard. Some of it is, I love obstetric anesthesia. And it's fun to like photobomb like the most important moment in a new family's life. And I'm in the background, 2 thumbs up, getting my picture in with that first family picture, and I'm there. And then there's sometimes where that kid doesn't make it, or that knowing that that kid's not going to play Little League, that kid is not going to their prom. Like, you kind of wrap your head around this in this moment, or they're not going home with this family. You're like, there are times where you're there for a known IUFD, and you're like, that kid is 37 weeks. That kid had a name. That room was painted. Like, that nursery was ready for them to come home. And I believe that I am the best person to be in that room to get them through this process. It hurts. It hurts bad during that moment. And for some of those times where some of these moms try to leave this world on my table, or they leave that table without that womb and they had no intentions of losing it, that's hard. And that takes some of the last few hours of my life. But what I'm comfortable with, that's kind of pruning. And I probably wasn't going to be able to wipe my own ass at that time anyway. And I probably wouldn't have recognized my grandkids either way. So you can take those years if it meant that I was benefiting, that people benefited from having me in that setting. But I do love it. I think I do great things. I have also the benefit of having a lot of like tangible change. Like, I inject local anesthetic around your brachial plexus and your arm goes away. You had pain after surgery and is it there anymore? No? You're welcome. This rip-roaring contractions that makes you want to run out into traffic, I make that go away and you're ready for your nap. Think of me before you fall asleep. Like, those are really nice things. Like, you make a woman's contractions go away, they will name their kid after you. It is really nice. These women are like sitting there like, I love you. And the husband's in the background going, they're like, honey, I love you too, but this guy is my favorite right now. Like, that's really fun to be part of. And if you can kind of enjoy that moment, it's nice.
So maybe you could wrap us up by telling us a bit about work-life balance in anesthesia. What are some ways that you strike a balance between your personal life, your family life, and your interests versus your work responsibilities? And how do you think anesthesia fits into all of that?
Great question. Now, I will admit, out of the gates, I was not prepared to answer this question for you, and I probably would have made some of the students run for the hills and not consider anesthesia if you looked at my work schedule. Now, I was very lucky that in academics, you can do fee for service and pick up extra calls. I was very proactive and practically doubled my salary in overtime. I did, unfortunately, watch my kids grow up in the background of FaceTime during that, but I now have a view of the water from this room that I'm sitting. So for that, it's kind of nice. There is, within anesthesia, there is an ability to have a work-life balance because of that shift work feel of it. Basically similar as ED. You can say, I'm going to do 3 shifts a week. Now, with that, you'll be reimbursed less for your time and you might get potentially less benefits or some other things, but you can say, I'm going to be here for these hours that you can use me. And then after that, I'm out. It might interfere with other hats you'd like to wear, be it administrative roles. You might not be able to do it, but if you're coming in here and saying you can plug me into the anesthesia, the surgical machine, and plug me into an OR 3 to 4 days a week, you can have that balance. There are some, people that have pushed back starting their families until after residency and now would like to have a little balance and spend a little bit more time at home. They can kind of move things around. One lovely thing has been an increase in reimbursement for our services. And there's been a little bit of a recent boom in terms of salaries. Now, what's been nice for me is I think maybe a year or two earlier, I might have said, oh, great, that means I'm just going to have that much more money. But what I've now done is now I realize that I can, have the same W-2 at the end of the year, but not have to bleed for it. So now I've been able to back off on some of that extra call that I do. But, it's a fee for service in many of the things that we do. I'm not getting, I don't want to nitpick it to the point where I'm like billing for each case I'm doing, but the more days you're on, obviously the department's going to have to pay me more for it. It's not the case per case, but the time spent. I think having to realize what is the priority at different points in your life is helpful. Now, one thing that I had said that I knew I wanted to provide. Now, one thing that was kind of skewed because I had my children at 28 weeks. They spent 100 days in the NICU. I would love to do the most that I can do for my children at this moment while they're sitting in these 2 little isolettes. How do I provide for my children? Money. And then I basically did everything I could to acquire as much money as I could to make my children have anything they needed. And I wasn't sure what that is. There was a lot of advocating, making sure my kids had resources. And I, crazy as I was, I sold every single vacation day that I had because I heard I could do it for cash. With that, I used it for lawyers and advocating and all these other things. But I've now we've gotten a nice little setting and our kids have the right services and I feel good about the setting we're in. And I'm starting to take some of that back. And now I get to spend some time with my children. As I said, I live on the water. I get to do fun things. I spend every weekend in Stowe with a sit ski that costs more than my car. And I bomb down the mountain with my daughter at 35 miles an hour. Like I do some fun things that are absolutely amazing. I play a large role in a company called Team Impact, which I'm going to pump right now. This is a company that basically pairs adaptive athletes like my daughter with severe special needs with collegiate athletes and get them on teams. And now I've been spending an awful lot of time with Team Impact, raising money, making awareness, empowering other parents of severe special needs kids to get their kids on teams. This Team Impact thing has deep pockets. They have these very wealthy donors that want to be a part of this. Every single collegiate team wants one of these kids on their team. The problem is convincing a special needs family to say, sign up for this. You're like, how many hours is this? Am I going to be able to do it in between PT, OT, speech, all these other therapies my kids need to do? And we've been working on empowering those kids to do it. So that's been a huge part of my life that now I'm able to do with letting go of some of my hospital stuff. So I've been able to find a blend. But when the boat is in the water, or the sun is shining on the beach, or the snow is falling in the mountains, I'm out of here. I'll do my amount of calls that I think I need to do to support my family, but I can let go and dial back. And that's really nice about this kind of stuff.
That's amazing to hear. Dr. Stiles, we want to thank you so much for all of your time, your thoughtful advice, and the exciting stories that you've shared with us. We really appreciate you.
Thanks for considering me for the podcast. Pressure's mine. Thanks, team.
Thanks for tuning in to the What the Health podcast. Please be sure to check out our linked resources at the Stony Brook Medicine YouTube channel. See you next time.